All right, as I said, thank you very much for having me. And I prepared some notes, and I will make sure that I will mention everything that I planned to mention today. And I would really appreciate your questions at the end of this presentation. So just an overview of our session today. At first, we will talk a little bit about psychological conditions that normally associated with Parkinson's disease. Then we will talk a little bit about dynamics between carers and people affected by Parkinson's disease, how relationship could feel and look different as disease progresses. Then we will mention, just touch base on some wellness strategies you could be adhering to now to prolong the wellness, living with this condition, and then just guide you where you can seek further support if you would like some psychological interventions as the result of listening to today's presentation. Okay? So common psychological conditions that we will cover in today's presentation would be depression, anxiety, impulse control disorder, psychotic symptoms, of course. So being diagnosed with Parkinson's disease can trigger depression and anxiety. Some studies mention that up to 40% may report the symptoms during progression of the illness. And adapting to the disease involves many adjustments to a person's life and can dramatically affect how the person functions. And it brings changes to personal social life, work pattern, financial situation might cause a lot of stress and sadness. You might have to deal with chronic fatigue on a regular basis, that energy levels are not the same as they used to be, and along with worry about your future. So a relationship between psychological health and Parkinson's disease is also not very simple. As I mentioned, it could be a reaction to something that's already happening in your life, but it also could come from within you because of the changes in brain chemicals caused by Parkinson's disease. And it may alter your emotional processes, and it may cause mood changes. And in fact, changes in the brain may put people at risk of mood changes in the longer run. Especially as physical symptoms of Parkinson's disease gets developed down the track. So in most cases, the coexistence of the condition is thought to be a combination of biological changes and reaction to life changes as well. And chronic difficulties adjusting to major life changes can result in negative or fearful interpretations of life events, which may further reduce your self-esteem, increase guilt, interrupts your concentration because you're constantly going to have this intrusive worries, can undermine some social interaction, and in addition, such thinking can have physiological consequences like poor appetite, disturbed sleep patterns, agitation. Some people might experience like slowness, like retardation. So depression, what is depression? I guess everybody talks about it. But for us, as psychologists or health professionals or doctors, there are few symptoms you have to demonstrate for you to get this diagnosis. First of all, low mood that has to last at least 2 weeks or longer, not just 2 days of low mood and then you feel great again, and then another 2 days of low mood in reaction to something, and then you feel great again. It's actually consistent, pervasive low mood for 2 weeks or longer. Okay, it's a serious illness that can have severe effects on both physical and mental health. Very difficult to treat if you just allow it to slide. So it's better to do it earlier than later. As people with depression find it harder to function every day. Eventually, you might feel the loss of interest in previous life activities when you just sense this lack of interest, vitality, nothing brings enjoyment anymore. You may constantly feel like frustrated, unable to find pleasure, feeling worthless, your thoughts may slow down, and sometimes the actions might look as just desire to withdraw yourself from things, from life events altogether. It is important to note that the typical pattern of symptoms of depression may be different from people with Parkinson's disease. People with Parkinson's disease are more likely to display lack of interest, experience fatigue, pessimism, and behave in a way that is irrational, and they may feel irritable. Like, for example, feelings of worthlessness as such is maybe not as common in Parkinson's disease, whilst like things like lack of interest, apathy, just can't be bothered with this life, with initiations. It's something that used to be so easy and I used to enjoy it, simple tasks, now become like a chore, and I can't be bothered because I don't see a point even attempting it. Okay, moving more on other symptoms of depression. So these symptoms may present or may not. The previous symptoms almost always present, and they have to be present to get a diagnosis. These symptoms may happen or they may not happen. So change in sex drive, you might feel absent and reduced as a result of depression. Thoughts that life is not worth living might start creeping into your mind. Fatigue, insomnia, weight loss, they are here in the bold letters, is specific to Parkinson's disease anyway. So you have to be careful that if you just have fatigue, insomnia, weight loss, maybe it's not a sign of depression and just a normal part of suffering from Parkinson's disease. Although with weight gain, appetite changes when you sleep too much rather than less may signify that there's more depression than anything else. So depression may affect multiple domains of functioning, like cognitive disturbance, mood disturbance, vegetative changes, as I mentioned just before, excessive muscle tension you might feel already on top of high spasticity, gastrointestinal problems, erectile dysfunction, and people who suffer from depression tend to report less quality of life as a result of their suffering. So let's just touch base on what is anxiety. Anxiety is commonly described as excessive and unrealistic worry. And it further complicates Parkinson's disease outcomes. So basically, anxiety, when it occurs, we might describe as discrepancy between how a person appraises the resources and ability to cope with some hardship and the actual resources and ability that is required by this hardship. So if people appraise that there's no way I can deal with the situation, of course, anxiety heightens, becomes more prevalent. It also could appear on the background of chemical imbalance in the brain, when people might display fear or worry, and you might not even have worrying thoughts as the cognitive component of an anxiety. You just feel physical component of an anxiety. And we talk about physical things in the next slide. So how it does complicate things, that pre-existing anxiety may get worse, that you might develop fear of falling as your motor function further progresses. If you experience any sort of problems with swallowing, some people may develop fear of choking even. Sometimes people start avoiding certain things that trigger fear, like avoiding walking on uneven grounds, avoiding walking if you don't have anyone with you by your side. So let's go on to physical symptoms. And physical symptoms are usually the most unpleasant and often can be catastrophized and interpreted as there is something considerably wrong with you health-wise. And sometimes people truly believe that they're having like heart attack or some other kind of attack, and present at emergency departments trying to find medical intervention for actual anxiety symptoms. So the common physical anxiety symptoms, apart from thought racing, is the changes in vision, that you might feel that it becomes more blurry, like everything becomes like very vague around you. Mouth is quite dry, and frequently dry, unprovoked, like not on the background of taking certain medications. That heart beats faster, you have these constant palpitations, that you feel this churning in your stomach, feel nausea, hands get cold, palms get wet, muscles get tense, breathing becomes quicker and shallow, and may result in hyperventilation episode, which is further down, sliding into panic attack. The hormones that maintain that anxious state within our body is adrenaline and cortisol, that is just injected in our bloodstream and makes us feel this way. You might feel urgency to empty your bladder, and just actually have a frequent urgency of urinating on an anxiety background. Okay, something I think also important to reflect on now, although this particular disorder doesn't come into your life until much later. And it's called impulse control disorder. And it's the most distressing one for people with Parkinson's disease, the most sort of like affecting their mood and reaction to it, and as well as it's very distressing for carers to experience as well. This impulse control disorder is mostly associated with dopamine replacement therapy, and you would have to be on dopamine replacement therapy for some time before experiencing the first symptoms of this disorder. But I think it is important to be aware of that now so you can plan ahead. So you might discover out of sudden that it would be very hard for you to control your gambling urges, for example. It would be very hard for you to delay gratification of any kind. If something you want it right here, you want it right now. Okay? So another repercussion, negative repercussion of this impulse control disorder is expensive spending. Sometimes people spend money that they don't have and spend it very, very quickly. The other one that is most distressing for carers and patients as well is constant preoccupation with sexual activity, sometimes preoccupation with pornography. And people even may have realizations that it's inappropriate, occurs in inappropriate places with inappropriate people. These fantasies occur, but not really able to modify it in any ways, and experience lots of distress. And sometimes, even if you do have dysfunction of the sexual function as such, I mean, like biological or physical, the thought content of sexual preoccupation still could be very vivid and present in your life. So this is something also to plan ahead, to understand that this is drug-induced thinking activity and is not my genuine desire based on my genuine values in life. And might have to plan and discuss together with carers ahead. So psychotic symptoms are also don't come straight away to people, and usually come on the background of very prolonged use of dopamine antagonist drugs. So commonly, these positive psychotic symptoms are present in such illnesses like schizophrenia, when people experience hallucinations or perceptions that occur without connection to an appropriate source in reality, seeing things that other people do not see. And hallucinations may be not just visual, they can be tactile, when people feel like crawling something on their skin. Some people might even receive messages of any ideas through their skin as well. And Or sometimes people might have olfactory hallucination when you smell things that are not there as well. So researchers also estimated that about 40% of people who have Parkinson's disease will experience hallucinations at some time of the progression of their illness. Delusions is more like fixed, false beliefs, overvalued beliefs, illogical and irrational beliefs, often can manifest as a paranoia, so believing that somebody is planning to harm you or somebody is after you, and or jealousy, when you might experience beliefs that people you really, really love are there to betray you. Some people have very extravagant beliefs that you have special powers and things like that. And yeah, so all Parkinson's medication have propensity to cause the symptoms. So these symptoms are quite distressing, and therefore, even if they're non-distressing, please report to medical team before they got out of control, because they can be modified with appropriate medications and with appropriate treatments. And for carers, the general advice is usually to avoid arguing, to avoid reasoning, to avoid trying to explain that people are distressed about something that are not there, that they believe in something that doesn't exist. So usually soothing down, calming down a person, try to seek appropriate treatment is the most advisable way of action in this instance. So why it is important to talk about psychological problems in Parkinson's disease? And I'm so sorry that it's probably one of our last sessions that you are attending. And at the same time, I think it's quite important to mention that is because it is associated with lower quality of life. And sometimes depression and anxiety can be more disabling than Parkinson's disease itself. And treating depression and anxiety is vital for maintaining that quality of life. If untreated, depression and anxiety can increase feelings of isolation, social isolation, because often even carers or friends cannot deal with people who suffer from these particular disorders anymore. It's almost like you can lose some special, some meaningful contacts in your life. That's why it is important to target these symptoms sooner rather than later. It can worsen physical symptoms, as I mentioned, of Parkinson's disease, and like anxiety, for example, associated with more severe gait problems and more uncontrolled movements and freezing as such. And depression and anxiety, along with like delusional problems or hallucinations, also seem to be very much related to cognitive decline in Parkinson's disease. And I know that you already had a session on cognition in Parkinson's disease. So Parkinson's disease sufferers with major depression experience much faster cognitive decline than anyone else. So when to get help? So when you start noticing, as I mentioned before, persistent low mood, not just for 1 or 2 days in response to some legitimate, very sad life event. Sometimes for you to feel depressed when depression kicks in on a background of chemical imbalance, you don't even have to have anything particular happen in your life. It just happened to you because it's physiological processes that change in your brain. When you start feeling that these changes impact your everyday life, that quality is just sliding away from you. When you feel frequently overwhelmed, like I had a patient who felt absolutely out of wits how to fill in car registration paper, when in that segment when you have to tick which insurance company you have to go with for third-party insurance. Even just reading from this very simple choice out of 4 insurance companies becomes very overwhelming. When you start experiencing physical symptoms of anxiety, also is advisable to seek help, as I said, because people often overinterpret physical symptoms as something wrong with them physically. And and it adds to distress that people experience. And of course, avoidance can limit and make you impoverish your life as it is. And psychotic symptoms can be quite distressing. So, moving on to carers and relationships. I found also there's a practice if people get together as a couple or as a carer, because sometimes not necessarily husband and wife, it can be parent and child, dyad. If you can sit down and explore potential differences in views and expectations now before you declined, whilst you're still high functioning and independent. And the reason for that is that we never tend to plan or look forward to aging, or that we're going to become more frail or more dependent as develop more health frailty. So we might spend considerable time and effort and energy to plan our adulthood, but aging and health problems we prefer to avoid and not to consider, like ditch the subject as almost as if it's going to happen naturally by itself. And we do adopt quite maybe unhelpful belief about how great we should be at coping, how great we should be at dealing with hardships. And it is perpetuated by media resources, because similar how for most of us it's impossible to meet the standards of physical beauty that media portrays to us. I found some people report that even feel good stories, like about dealing with mental health problems or dealing with physical disability, or living and caring for a disabled child, because we usually see on TV and read in paper about people who do very well, who achieve very much in these areas, whilst most regular people actually feel frustrated and feel very unhappy, and they don't cope well at all times. Sometimes they do feel desperate, and it's okay. So exercising certain like kindness and compassion to yourself, that not everything going to be great, and that's okay. It doesn't make you a bad person. It doesn't make you this great that you're not able to achieve this great ideal that can be portrayed elsewhere, because it's just not realistic to achieve at all times. So coping and resilience also should be tested on a continuum, allowing space for setbacks and recovery before moving forward again. There are a few metaphors you can use in that, but I think I will mention them later on when we will talk about strategies. So, aging, health decline, and providing carers duties to a person affected by a progressive condition will never be equal. And it's something we never can expect from each other, because health and enjoying good health in later life is almost like winning genetic lottery. A couple, both like people in a couple might eat the same diet, might the same kind of level of exercise and adhering some other wellness routines, and one person might get sick later in life, and some people might enjoy good health for the rest of their lives. So it's never given. It's like a lottery, and it should be taken as a lottery, as almost like a gift and not a right. Actually, becoming sick and becoming unwell is more normal as we age than not. And that carers and dyad, things may not be reciprocated. So a person who cares for someone might end up not having a carer in the face of their partner at all, because the partner will never be able to reciprocate in the caring responsibilities. And that's also an additional thing for you to reflect and exercise acceptance about, that it's okay that I might provide this care which will never be reciprocated, that my partner will never be there for me when I need help. So how do I plan for it? Who will be caring for me when I need help? And of course, taking care of yourself and be very kind on yourself as a carer is also important, because the longer you last in good health, the better it is for your partner. The other things to consider as well in the relationship, and I actually recommend to organize a time, just put aside a time, take a diary, take a pen, and sit down and actually write agreements down that you can refer to later on as the illness or disease progresses in one of the partners. Because you might have to discuss now about possible role reversal. If one of you used to be a primary caregiver in terms of hands-on care, fixing up things, how these responsibilities and tasks going to be taken on by a carer later on down the track, or what plan of action you're going to take maybe to outsource some of these responsibilities. And the same goes with for leadership roles, who makes decisions. If you didn't have, if you have really distinct leader and distinct follower. Financial management, like if person who is affected now with Parkinson's disease used to be solely responsible for financial decisions and management and bills payment and things like that, you might want to sit down now and train this other person how to do these duties down the track. Household care task, that is another one which is very hard to adjust to, but not impossible to adjust to. Most people adjust to it. And then earlier you start talking about it, again, it will enhance your adjustment down the track. Like, for example, I found like couple might not have the same ideas about what the cleanliness standards, what is the cooking standards, what kind of food we buy at the shop standards. Like one person might think that I need to do vacuum twice a week. Another person thinks that I just do it once a fortnight and it's fine. So we need to discuss these discrepancies now and how you might choose to meet each other in the middle. I knew a couple in the past where wife was major cook, and as she deteriorated in her physical health, husband just resorted to buying takeaway food all the time. And both of them were on a pension, which really, really affected them negatively financially, because money just would run so short after 1 week, after getting the payment, and basically having no food for the second week of the fortnight. The other touchy one is a personal care. I think for almost every human to accept personal care from another human is a huge ask that requires lots of thinking, trialing and error, training certain flexibility of the mind, and it comes accepting personal care from a partner or accepting personal care from someone from a carers agency. So also would recommend to sit down and outline the degree to which a partner can commit to certain personal care tasks, and the degree to which partner might say now that I don't want to sign up for this, I don't want to sign up for that. And it will be much better with less distress to have this conversation now. So you can plan ahead that once I won't be able to do this personal care, I would have to outsource it, and that's how it's going to look like. The other thing I just mentioned here, because it's also very important, I think, to outline now, is that as we progressively age, the amount of touch and hugs and just general tactile communication decreases. Because when we're young, and when we're young in a relationship, it's often present at a greater degree. When we have young children, it's present at the greater degree. But as we age and our children are growing up, we get less and less actual physical touch. So it's quite advisable, maybe write it down, that we maintain our daily hugs, and our daily hugs gonna last that many minutes. It is important for us to stay in touch, literally, to enhance our mood, to make sure that we're maintaining good quality of life. And of course, spending time together is another thing that you might need to plan, because if both of you sort of working now, then as you age, you're going to spend more time together. How this time together going to look like is also worthwhile to discuss now. So let's talk about strategies now. You already had probably the whole hour on why mindfulness is important and how mindfulness can enhance your life, quality of life. So I just will mention more like psychological points why it is important. So first of all, I think mindfulness teaching us that suffering and discomfort as such is a normal part of universal human experience, that suffering is actually more normal than not, and suffering is similar to opposite emotions as happiness, excitement, is a very kind of transient emotions. They come and go, especially if we sit with it mindfully. We can learn essential impermanence of any emotion, because most of the time we actually feel quite neutral in this life. We don't feel like extremely low or extremely high, unless you put yourself with that, either with something happening or with substance and things like that. So another thing that mindfulness practices can assist you with is to explore the subject between acceptance versus struggle, because it does teaching you to accept things as they are in the present moment, non-judgmentally. So when you have a pain for the pure quality that this is painful, we call it clean discomfort, like a pure discomfort. And when we try to struggle against it, when we feel upset, feel distressed about that we are having this suffering in the first place, that there's no way we should have it in our lives, there's no way it should be even sent to me as a chore or as a cross to bear, then we call it like dirty discomfort, because you don't just have pure pain of pure suffering, you also have this distress and struggle on top of it, which is maximizes suffering. The other thing with mindfulness is it does teach people to accept situation non-judgmental. Try not to change the situation. Try not to change your thoughts, feelings, or urges, but just allow them to come and go. Just come and go as impermanent events of our mental life. So noticing rather than reacting to things. You can introduce formal or informal practices to your daily routine. So formal practices, it would be the exercises that you did during that mindfulness training that you received, when you allocate the time where you practice mindfulness, when you put a track on, if you want to have a guided meditation, or you can guide yourself. And informal practice is usually refers to staying present in a moment when you incidentally do something throughout the day. Like, for example, when you go through the doorway, you're actually noticing the touch and pressure of the door handle as you're crossing through the doorway, or getting in and out of the car, or be fully present for the sensation of water against your skin in the shower, for taste and texture of the food during eating, how your posture feels, how your grip with the ground feels during walking. Okay, mindfulness doesn't mean that you approve the situation or you have to like the situation. It's more about like setting priorities. The other thing is advisable is to learn effective relaxation techniques like progressive muscle relaxation, when you tense and let go of groups of muscles. From some people start from toes to up, some people start with forehead and go down, and basically slowly tensing and relaxing different groups of muscles. Just retraining your brain how relaxed feels like, because as plasticity progresses, sometimes brain loses that ability to feel how relaxed muscle actually should feel like. Learning to control your breathing is another useful strategy, and the other technique that is trained is called deep diaphragmatic breathing. Diaphragm is this organ that divides your lung and stomach, so sit somewhere here, just in the bottom of your ribs. And research again showed that we need to aim at breathing at 10 seconds intervals, so about 6 breathing breath cycles per minute, where our out breath is twice as long as in breath. So if your inhalation will take 3 to 4 seconds, then exhalation has to take 6 to 7 seconds. And I found, like, if you put your lips in a small hole, like purse your lips, like, you are able to prolong your out breath to a significant amount of time, like that. And now, until your lungs absolutely empty, almost like allowing lungs themselves to feel where they need air and to take this breath at the end of your exhale. So practicing deep diaphragmatic breathing is usually easier when you lie down on your back, when you can just see your tummy inflating, ballooning out, and then just gently falling down as you breathe out. Okay, and eventually you can start practicing while sitting up, while standing up, but lying down on your back, sometimes with your knees bent, is the easiest way where you start your practice. The other important frontal lobe function enhancing. Yes. The other thing that mindfulness is good at is that because our frontal lobes, and Louise probably already mentioned, is the most fragile function that affects or gets affected by most neurological illnesses or blows, like mechanical damages. And mindfulness is actually able to enhance this function to some extent, because you're retraining attention through purposeful attention paying to a subject of your choice. And regular mindfulness practices usually would instruct you focus, for example, to taking in your breath going in and out, or the sounds you hear, or any other sensations that can come in the present moment, like maybe even try to experience the light breeze against your cheek. And then you will inevitably notice that your mind wanders away, start planning the day ahead, maybe your shopping trip or whatever, and then you notice it's happening, and you just gently bring yourself back on the subject that you chose to focus on. And that can enhance the frontal lobe function, that particular practice, allowing mind to wander off, identifying when it's gone off to, and then bring it back to whatever things you decided to focus on. Sleep disturbance or insomnia is one of the very common complaints, unfortunately, that people have with Parkinson's disease. So cognitive behavioral strategies for sleep or insomnia treatment usually goes within these lines, that you go to bed at the same time and you wake up at the same time. And actually waking up at the same time is easier to instigate and regulate than falling asleep time, because sometimes falling asleep when you have sleep disturbance is not really guaranteed that you're going to fall asleep within 7 to 30 minutes after hitting the pillow, but you always can guarantee that you can put alarm clock and you're going to get up at the same time every day. So basically, together with a regular getting up or waking up routine, it's advisable to avoid all napping during the day. So we need to create, no matter how hard it is, for 1 or 2 weeks in a row without giving up on this strategy, create a pressure to sleep, that you are not relieving through naps, and that you are not relieving through intermittent sleeping in from time to time. So if we're serious about treating insomnia, we can't allow ourselves to sleep in ever. You would have to adhere, like if you commit to wake up at 7 or 8 o'clock in the morning, that's where you will be waking up even on weekends. Because each of us need a certain amount of sleep in 24-hour period, and we need that amount. So we need to create that pressure to sleep. So you almost have to go into sleep deprivation before you will start noticing improvement in your sleep. The other advisable strategies that consistent with the sleep hygiene is, it's not advisable to lie and stay awake in bed for longer than like 5, 10, maybe 15 minutes maximum at a time. So bed should not associate with a torture, that you're lying there and tossing and turning, tossing and turning. If you cannot fall asleep within 5 to 15 minutes, then get out. Especially now it's getting warmer. You have to get yourself into different, maybe even room, and read. And reading usually can provide, or some other activities, cannot be screen-based activities, anything else but screens, or passive entertainment like TV. Reading can provide that necessary focus for your brain to have to start feeling sleepy again. So basically, then you go back to sleep, and if you again not able to fall asleep, then you have to get out and read more until you exhaust yourself and you actually do fall asleep. So you just continue repeating this routine. And I know it sounds tedious, but this is how behavioral strategies works. And all behavioral strategies would require at least 3 weeks adherence before you start noticing the good outcomes from that. And even if these behavioral strategies do sound scary, I still believe that they're totally worthwhile, because having good sleep, which is not dependent on medication or alcohol or other substances that people might use to put themselves to sleep, is really, really precious and adds to quality of life. So another advice is to avoid all this caffeine, nicotine, all the stimulant drugs. Alcohol, because it has a very short metabolic life, what people might discover, even though it puts you to bed, but your sleep tends to become very shallow. You never sometimes develop a deep sleep stage, and people sometimes tend to wake up within 4-hour interval. So for example, you do fall asleep because of alcohol, but you wake up from a shallow sleep 4 hours later. So it doesn't really assure any restful sleep or any longer sleep than you would if you didn't drink alcohol before bed. So clean, fresh air. Try not to exercise at least 3 hours prior to bedtime. Try not to have clocks near your bed, on your bedside table, because this clock watching can increase and enhance this anxiety response. And if you have these amazing ideas, and sometimes amazing ideas and thoughts come at night time, and you feel that you're obliged to catch on this idea and spiral down and developing them, trust me, they will become not very important in the morning, or you might forget them in the morning. So basically, have a notepad near your bed, on your bedside table. Write this idea down and say to yourself, I don't have to think this thought right now. I will think about it tomorrow when I actually have time and place for it. So, behavioral activation. The other thing I think I didn't mention explicitly when I talked about depression is that depression tends to cripple motivation. Like, if in a normal functioning, we sometimes also may procrastinate things and put things, I'll do it later. And eventually we actually do them later, like 2 or 3 days later, within normal functioning, we attempt to do this task again. But in depression, this inspiration to do this task never seems to come. And things tend to pile up. And as things pile up, they become even more scary to tackle. So sometimes what needs to be implemented is that you do things and you can break them in small chunks, and you do just manageable chunks at a time before you feel like doing them. So action had to precede motivation. And just adopt that Nike slogan, just do it. Don't sit around, don't feel like, I just don't feel like it right now. I don't feel it like right now. You will never feel it. You just have to do it, even if it's for a short period of time, just because. And eventually, again, after 3 weeks of this behavioral implementation, you will feel that motivation is coming back slowly. You actually want to do this action because you feel rewarded through doing this action. And it was just a recent research from St. George's University in London. They just discovered apparently there is no such thing as a willpower if you constantly surround yourself with temptation. So basically, if you have so much temptation around you, and you think you have the strongest willpower, most likely you won't be able to resist. Maybe the first day, maybe the second day, but the third day, you won't be able to resist. Like, for example, I think the example they used is that if you decided to implement like regular exercise into your daily routine when you come home after work, then make sure that you avoid the couch. You don't even look on it. You don't even passing through it. You avoid the couch, you get home, you get changed, you're out to do your walk or exercise, whatever you decided to do. Because that couch may act as a temptation, especially on some rainy days like we have it now. So scheduling regular activities, whether we like them or not. And another thing quite powerful in depression treatment is that adhering to activities of two types. Some of them can be really not enjoyable, like doing your tax return, but can bring you great sense of achievement as a result of doing it. And some things like having a friend over for coffee or go out for coffee, maybe it doesn't really seems or feels like a great achievement, but it could be very fun and pleasurable. And sometimes you can, even in dedicated way, treat depression like that you regular schedule the things you do for fun, even if you don't feel like doing them, and the things you do for sense of achievement, like going through your bills or whatever, or cleaning your house, even if you don't feel like doing them. And eventually, in turn, at the same time, like about 3 weeks, you start feeling the sense of reward from scheduling these activities in your life. The other things out of this list, I spoke to Kate yesterday, and she mentioned that apparently there are some activities you can access through Parkinson's ACT, like I understand painting with Parkinson's ACT, or dancing with Parkinson's. I don't know if you want to get together and organize some maybe cooking activity or cooking classes. I know some people try to stay socially connected through group activities, and sometimes even maybe if you find like-minded people, you can organize a walking group, like walking with Parkinson's group, if you like. All of these activities are aimed and proven through research again to enhance the quality of life dramatically. Cognitive restructuring usually performed in your work together one-on-one with a therapist, but this is just a simple strategies you can use for yourself. Is learning to treat your thoughts as just mental events, like similar how breathing is an event of the respiratory system. Thoughts also just mental events. They just come and go, and we don't have to hold on them. We don't have to hook on them, to develop them, snowball them, spiral them down. We just have to develop a capacity to treat them not as fact, especially if they're unhelpful or distressing, and in mindful way allow them to enter our mind and leave our mind without hooking on them, without getting on a train with them. So even though the thought may be based on real fact, like for example, I don't like what is happening with my body, you can say to yourself, even if it's based on truth, it is not helpful for me to give it full attention, because deliberating on this negative thought for too long only going to cripple my motivation and make me feel bad about myself or my future or the world around me. Okay, so you can choose to allow that thought go only on the quality of not being a helpful thought, because usually self-punishing, self-critical, self-negative thoughts never ever constitute any wellness, only result in more withdrawal and more kind of wanting to escape things, stop engaging in things. The other question you can ask, does it add to my quality of life, thinking this thought? And if it's not, the thought comes and the thought goes. Or you can put it on the shelf and say to yourself, I think that thought later. Yeah, and as I said, if you struggle on your own, seek professional help. It always can be more fun. Some people find that setting goals can be very like life-enhancing experiences. I'm just a bit worried about time, so I probably just will rush through this slides. So basically, the advisable format for goal setting is for them to be specific. So you need to identify exactly what you want to do. So it can be helpful when planning to consider what's the barriers you would like to overcome, and how you're going to overcome the barriers. So goals have to be measurable. Like, for example, how would you know that you achieved that goal? Okay. Then goals have to be realistic and achievable. So it's not too big a step from what you're already doing now. Okay. And yeah. And if it's such a big goal, then consider how you can break it in smaller steps. So along the way, it does feel like achievable and it does feel like realistic. And you should have a certain time frame to keep you on track of achieving this goal. So if sometimes in a height of apathy or low mood or whatever, sometimes people feel it's very, very hard to make decisions as well. So sometimes reflected on advantages and disadvantages of certain decisions and just write them down. You can write, have two sheets of paper and one sheet of paper, pluses for this decision, disadvantages with this decision, and on a other piece of paper, the same but for alternative decision. Like, for example, if you're tossing and turning between two different things that you cannot decide, do concurrent analysis of advantages and disadvantages of both in writing, so it's more clear. So it's not just crowded and fused in your mind, it's actually right in front of you on the paper. The other thing to remember that road to success is never a straight line. So success is the effort and willingness to make attempts to change over time. And these metaphors that I wanted to mention before, the helpful one I found is that it's okay to have a bad day and it's okay to have a setback. And it doesn't mean that every other subsequent day from that bad day should be the same bad day, okay? Because when you accidentally break a plate, you never say to yourself, oh, well, I might as well just break all my plates. I already broke one. You usually stop yourself and you learn from that experience and you try not to break any more plates. Or if you trip over a step, you don't say to yourself, okay, I might as well just keep falling down the whole flight of stairs, given I already tripped over one. You learn from that experience and you try not to trip on subsequent steps after that. Similar with setbacks or bad days, is that it's just a bad day. It doesn't mean I have to continue tripping down that bad day's pathway. And here is basically how cyclicity of change may look like. That sometimes we might just contemplate about change, thinking about change, then even plan how it's going to happen, actions a change, and sometimes not quite get there. Like, for example, if we decided to do exercise to be part of our lives, regular routine with no day missed, sometimes you will be relapsing based on weather or based on temperatures outside, like too hot or too cold, whatever. Just be prepared that this cycle that you see on your screen, even in the highest committed people to change, may happen up to 7 times before the permanent change occurs. So another reason, even if you're relapsed in some not helpful behavior, it's not a reason to give up and not continue on actioning the change again. So where to seek further support? As Kate mentioned before, I work for Rehabilitation Aid and Community Services, and we do routinely work with people with Parkinson's disease, and we work in multidisciplinary component, like together with occupational therapists, physiotherapists, speech pathologists, and our service would require referral from GP. And for psychology, it may sometimes be up to 20-week waiting list. And we are based at University of Canberra Hospital. If you would like to seek psychological intervention through private sector, then you can also, again, see your GP, and then you develop a mental health treatment plan to access Medicare rebates. So basically, you see a private psychologist, and some part of that fee will be refunded to you via Medicare if you have this mental health care plan developed together with your GP. And right now, because of COVID, the amount of sessions that you can access under Medicare rebate is increased to 20 per year. It used to be 10 per year.